Okay, I think we'll get started. We have a great attendance. We're thrilled about that. Today, certainly in a different typical daytime for our seminar. So we'd like to welcome Dr. Chris Haggerty for joining us today. And he recently, in October 2022, joined New York Presbyterian as the Director of Data Science and co-principal investigator of the Cardiovascular and Radiologic Deep Learning Environment with Columbia's Doctors Elias and Poderucha to help advance the development, validation, and clinical implementation of deep learning across NYP. His background includes a PhD in biomedical engineering from the Georgia Institute of Technology in 2013. Following that, a postdoctoral fellowship at the University of Kentucky Cardiovascular Research Center. He then moved to Geisinger Health in 2015. As a faculty member there in the Department of Translational Data Science and Informatics, Dr. Haggerty initiated and led NIH and industry-sponsored research programs related to cardiovascular genetics and machine learning from healthcare data. These projects include the application of deep learning to electrocardiology and echocardiography for prediction of clinical endpoints such as atrial fibrillation, structural heart disease, and all-cause mortality, and have resulted in several pending patent submissions, a breakthrough device designation from the FDA, and numerous high-impact publications. And so we welcome him today, and he will be speaking about precision cardiology with machine learning and genomics. Thank you so much, and welcome.
Thank you very much. I appreciate the introduction, the opportunity to present and speak with you all today, and obviously a bigger level to join the team and be able to work with many, if not all of you over the coming years. Just by way of quick disclosure, I want to mention a lot of the machine learning work that I'll talk about later in the talk was funded by Tempus Labs, and Tempus and Geisinger jointly applied for patents, and so there are some potential financial implications there. But that aside, want to just kind of quickly say that the overview for the talk is kind of twofold on a high level. So first, I'll talk a little bit about the genomic applications, the genome-first approach to cardiomyopathy and arrhythmia work that was begun at Geisinger and it is still ongoing there. And then the second part of the talk will focus on some of the deep learning work from cardiology, signals and images data work that has will continue as part of the collaborations here at NYP and Columbia and Cornell. Very briefly, to just set the stage for the genomic piece, this was made possible by what's called the Geisinger MyCode Community Health Initiative. This is a large research study that's been ongoing for over 15 years now, with a goal to sequence over 500,000 Geisinger patients. To date, something around 300,000 patients over that have consented to participate, and really this program has been in large part successful through collaboration with Regeneron Genetics Center, the so-called Discover collaboration, through which 184,000 patients have been exome sequenced and the data linked to the Geisinger electronic health record. And this program is really strong for a number of reasons, including unique aspects of patient consent for recontact, inclusive of return of medically actionable findings, which forms the basis for a lot of what I'll talk about here. So in terms of the kind of disease application that my research focused on, a little bit about that. This is arrhythmogenic right ventricular cardiomyopathy. This is a fairly rare condition among even inherited cardiomyopathies. This is a progressive fibrofatty degradation of the heart, and can often manifest in both right dominant or biventricular forms. It's been commonly estimated around 1 in 1,000 to 1 in 5,000. It's one of the leading causes of sudden cardiac death in young people, particularly young athletes. And from a genetics perspective, it's associated with variants in genes of the desmosome, particularly plakophilin-2. And so we envisioned this kind of idea of a genome-first approach to the disease in concert, again, with the genomic data that we had and our ability to recontact patients for a return of medical findings. So that paradigm looks something like this. If you have, in a traditional sense, quote unquote, a young, healthy, active individual who maybe develops vague symptoms and needs to go to the hospital to see a physician for diagnosis and treatment, or in some of the more extreme cases, those symptoms can be an immediate precursor acutely to sudden cardiac death. And that's obviously the situation we're trying to avoid. A genome-first approach perhaps gives us a good opportunity, meaning that we use the genomic data on hand to identify disease-associated variants and use that as a screening mechanism to indicate further testing, such as electrocardiograms or cardiac imaging, as you see here. And that can then be used by the physician for presumably earlier diagnosis treatment to potentially improve outcomes, halt disease progression. And just for reference, this is actually not a random physician photo. This is Dr. Hugh Hawkins, who's one of the disease experts nationally or globally, frankly, at Johns Hopkins, who's been a close collaborator of ours on this project since nearly its inception. So I always like to include him on that slide. Of course, that kind of genome-first paradigm is a little bit easier said than done. There's a lot of open questions, critical knowledge gaps to effective implementation, and kind of at a high level, I would break it down as such here. You start with a genotype of individuals with pathogenic or likely pathogenic variants. Once you evaluate that person phenotypically or for disease characteristics, you will either, frankly, by definition, find a phenotype that'll be phenotype positive or phenotype negative, and both of these have even subsequent questions that need to be answered. What is the penetrance? How many of these people will actually have a phenotype, and what mediates that for the interest of trying to reduce or prevent disease progression? If somebody doesn't have a phenotype, they're not necessarily removed from risk. That could be, in some cases, yes, non-penetrance, but there also could be pre-emergence that we're just looking at them too early and they will go on to develop disease, or it could be some type of novel presentation that isn't classically associated with the way that the disease presents in other settings. And of course, how do we go on to distinguish among these different options? So this is work then that my team at Geisinger helped to lead by first looking retrospectively within the data set there. Again, starting with MyCode, identifying patients with pathogenic or likely pathogenic variants, and looking at differences in the electronic health records that we could try to look for evidence associated with disease. And really what we found from here, I think, would help to start to fill in some of these knowledge gaps that we talked about. The prevalence of the genetic variants was much more common than the disease itself, which is perhaps not surprising. So 1 in 400 to 1 in 500 compared with, again, 1 to 1,000 or 1 in 5,000. This works out to about 6% in terms of penetrance estimate, which is far lower than the 40% penetrance that's classically described in familial studies. So when you look within affected family members, about 40% of close relatives will develop disease. And this was supported by, in many ways, limited evidence of related disease from health records. So 15% of the patients who identified satisfied at least what we call minor task force criteria. ARVC is diagnosed by kind of a point scheme, that there's major and minor criteria across a number of different categories. There's not a single gold standard diagnostic. So 15% of these people had some minor features associated with disease, but that was actually in proportion to the control patients that we identified. So even that was not conclusive of a finding. And again, this led us to, with support from the NIH, to continue to study this further research. So we were able to partner with, again, our genomic screening and counseling program to actually begin returning these results to patients in a clinical setting and following them prospectively to see what we would learn by having some result-directed testing in addition to some of just the retrospective ascertainment that we had previously been looking at. And this was published almost 2 years ago now, the results of that initial look at clinical findings and diagnostic yield, considering the first 92 patients that we had returned results to, and whittling that down to the 59 with some observed clinical evaluation. The results here matched fairly well with what we had seen in a retrospective setting. So here on the x-axis, I'm showing some of the different criteria groupings I referred to from a diagnostic consideration and consideration for the major and minor criteria here between the solid and the hashed lines. But you can see that overall, the y-axis being the patients affected in each category, not many patients demonstrating any of the specific criteria. From a classical ARVC presentation perspective. Again, thinking about this as maybe not just a right-sided disease, but also looking at potential left-sided characteristics. We tried to define features that might be considered for a left-dominant arrhythmogenic cardiomyopathy diagnosis, which is not something that there's actually consensus agreement for as yet. And you can see maybe a little bit higher yield here in terms of some non-specific arrhythmia or imaging abnormalities. But ultimately what we found or concluded from this was that there were 8 individuals in total that appeared to warrant some varying degree of diagnosis. And you can see that broken out in this bottom right panel here in terms of left dominant versus right dominant, or perhaps biventricular in the overlapping zone diagnosis. But I think kind of the take-home messages for the purposes of this talk was again that this was a situation in which we had many more people who were identified with a genetic predisposition than appear to have a phenotypic manifestation, but by being able to first retrospectively leverage the health record data and then subsequently engage with patients in a clinical setting, able to start to understand and appreciate the actual prospective risk that warrants. And I'll probably just end up repeating myself on my summary slide. So again, genome-first identification can uncover unrecognized disease, but most individuals identified don't have clinical evidence of heart disease. And so obviously the critical questions remaining include things like how to risk stratify within this quote unquote phenotype negative group, because we're going to have many people who will be under clinical surveillance under this type of paradigm that we need to help, provide guidance and counsel for. This approach represents a unique diagnostic scenario, and so distinct criteria may be warranted. And thinking about that in the context of things like this is a gene-first approach versus a disease-first approach, thinking about this in terms of the affected genes. So I mentioned PKP2, but there are a number of other genes that were similarly identifying as at risk for ARVC, but some of the evidence that we found suggests that the genes have differential risk profiles, and understanding that more. And there's an opportunity for technological innovation here, a role for advanced imaging perhaps to help identify subtle abnormalities that may predict future risk, applications of machine learning to assist in diagnostic predictions. And so a lot of these themes are factoring into our plans for submission of an R01 renewal. The team that is still at Geisinger leading this work, planning that for some time in the coming year. So I'm happy to pause here and take any questions on that section of the talk, or that I can continue and save questions for the end. I'm happy to do either. Okay, I can keep going. We can come back to it at the end. So moving on to kind of the deep learning piece of the talk here, starting with some of our work in deep learning of electrocardiograms. So the concept of automated ECG analysis is nothing new. Some of the earlier studies that I found that have talked about it date back to the early 1960s, but certainly in the past 5, 6, 7 years, there's been, I think, a relative explosion of these types of studies, thanks to the collection of large data sets, the overall increase in use of things like deep neural networks. And so this is an area that has really taken off in the past few years. And I think, from my perspective, it's really well set up for that application. The idea of machine learning enabled ECG analysis is really attractive because from a cardiology standpoint, ECGs are ubiquitously available, relatively inexpensive, and broadly indicated for use. And the context that I use to kind of frame that, again, hearkening back to the Geisinger MyCode population, which again is drawn from across the hospital system. Any patient in the system is eligible to participate. 70 to 80% of those patients have had at least one ECG in their lifetime. So a relatively broad subset of the population. Also, from a physiologic standpoint, ECGs are sensitive to changes in underlying anatomy and physiology. There are at least several instances where there's a strong linkage to prognosis, thinking of things like ST elevation, myocardial infarction, or prolongation of the QT interval. And so ECGs are well suited for ML augmentation to address specific diagnostic or prognostic questions, such as looking at concealed long QT syndrome or mortality risk, or for opportunistic screening, such as for atrial fibrillation, which I'll talk a little bit more about. Atrial fibrillation, of course, is a very common heart arrhythmia. It's our motivation for focusing on that from a disease standpoint is the fact that it's often asymptomatic, frequently paroxysmal, meaning that somebody who has atrial fibrillation isn't always in atrial fibrillation, can go back and forth between AFib and sinus rhythm, but it's associated with adverse outcomes, particularly stroke. And so screening to prevent adverse outcomes is of great interest. There have been a number of clinical trials in this area of trying to screen for atrial fibrillation in a population level. I've listed a few of them here. Many people will probably be familiar with things like the Apple Heart Study, right? Increasingly, this is the domain of wearables. And of course, this benefits from the fact that there are treatments available given appropriate recognition. So anticoagulation, initially with warfarin, but now with with oral anticoagulation drugs that have a better profile than warfarin, have shown to decrease that stroke risk. And so the hypothesis is that if we can use a deep neural network to help predict risk for new onset atrial fibrillation, then that could improve the identification of AFib and thereby help to reduce AFib-associated strokes over time. So we undertook a study to try to prove this out, leveraging historical ECG data within the Geisinger health system going back to the 1980s through June of 2019. We identified about 500,000 patients with resting ECGs, filtering some of these down here to create our training and hold out sets for our proof of concept model. Here you can see the numbers in terms of a million ECGs, over a million ECGs for 285,000 patients, holding out another 71,000 ECGs for validation of the model. And about 4% of that population had atrial fibrillation. And again, we're defining our cases here. The things that we're trying to identify with this model is new atrial fibrillation within 1 year, compared to controls who are patients with at least 1 year follow-up without atrial fibrillation. So this is the then overall model performance here. For comparison, we used a simple model of just clinical features, patient age and sex to provide a baseline for that comparison. And you can see the orange bars here represent the output of the model by itself. The blue bars represent a combination of the deep neural network plus the age and sex features added in to provide additive benefit as we observed. So here the x-axis is broken out into all ECGs and then subset into those that were clinically read as normal and clinically read with some abnormality here. But overall, what we see is we observe generally really good performance, mean area under the ROC curve, just over 0.84 in the all-comers model here, and you can see that that performance was even preserved within the subset of studies clinically read as normal, which for us was one of the more interesting findings here. Of course, because this is a highly imbalanced class label, we also looked at the area under the precision recall curve, and you can see here similar trends in terms of superior performance of the deep neural network plus age and sex compared to our baseline model alone. The next kind of interesting finding here was that the model prediction seemed to have prognostic performance beyond the time that it was trained for. So again, this was focused on new onset AFib within a year. But if we actually followed this out, given the longitudinal data available, you can see that these curves, which are represented by predicted high-risk group in the solid line, the predicted low-risk group by the dashed line, those curves continue to separate on this Kaplan-Meier survival analysis well out into 20 and 30 years after the ECG. So there's something that is, the model is learning that maybe it's a little bit more inherent. And I've actually seen studies that have done genomic associations with this type of analysis to try to bear that out. But nonetheless, it's an interesting observation that I think warrants further study that we didn't quite get into. But we instead focus the attention for the remainder of this study on simulating a deployment scenario, again trying to think towards that clinical implementation piece. So we retrained the model on data prior to an arbitrary point in time, in this case ECGs prior to the year 2010, defined a test set then for ECGs acquired in the subsequent 5-year period between 2010 and 2014. And cross-reference these against an internal stroke registry to try to ask a question about how much the model predicting patients at high risk corresponds with downstream stroke events. And so you can see here the breakdown of the number of strokes within our test set, about 3,500 strokes, and of those, just shy of 900 having a new AFib diagnosis within the year following the stroke. So presuming then, oh, sorry, one more click. 375 strokes within 3 years of an ECG that was then available for model prediction. So the goal of this experiment then was to evaluate the success of the model in selectively identifying high AFib risk within this group of 375 patients with AFib-associated strokes. And what you can see here then is the result of that analysis. So on the x-axis is the percent of the population prioritized as high risk, and the sensitivity on the y-axis, and then this is then the curve of model prediction. So as we pick an operating point along here, we can see what sensitivity for stroke that corresponds with. So at an arbitrary point corresponding with the F2 score, for example, you can see that the model for 20% of the population prioritizes high risk would capture about 62% of the AFib-associated strokes within this specific population. So that corresponds in this case with a number needed to screen of 162, which favorably compares to other clinical screening applications such as mammography, PSA, or treatment for cholesterol. So at least demonstrating a potential proof of concept here for this type of screening paradigm. And so just to summarize this piece of the AF model, we showed that ECG deep learning models can present an opportunity for a new paradigm of AF screening to help prevent stroke, with potential for better positive predictive value and specificity in detecting and capturing undiagnosed AF than things like age and clinical factors alone. And this was, Sarah mentioned in the intro, the FDA breakthrough device designation. This was the device that Tempus received that approval for, so development is still ongoing there. moving on to, in addition to looking at atrial fibrillation, there's also a popular paradigm of looking at cardiac structural abnormalities with deep learning. This is something that, again, has gained increasing attention in recent years. People looking at aortic stenosis, hypertrophic cardiomyopathy, or cardiac contractile dysfunction. The novelty that we brought to this concept is to think about it a little bit differently from an endpoint perspective. So the models that I just spoke of were kind of this single model per endpoint approach. So you have an ECG, you train on a neural network to detect that endpoint such as aortic stenosis, or you have a network trained to detect low left ventricular ejection fraction or a thickened interventricular septum. All of these endpoints, as you'll see here, in this scenario at least, drive the same downstream clinical action. You need an echocardiogram to evaluate and confirm the presence or absence. So we had the idea to group these together into a composite label. I think, very cheekily called this the recommend model, to group a bunch of these endpoints together, since they all would result in the same response clinically, to try to benefit from the aggregate increase in label prevalence. And here's the results then of that kind of high level evaluation. Here you can see again that our composite recommend label was present about 18% of the population, compared to much lower percentages in the member endpoints. And so we observed then an improved performance as a result of that. So the area under the precision recall curve for the composite model of 0.71 was superior to the AUPRC for the individual components. And we also achieved a better positive predictive value of 42% at a specified sensitivity value of 90%. Again, trying to put this into context, then moving from strictly a retrospective cross-validation into something that emulates a clinical deployment scenario, in the same fashion as the AFib model that I mentioned before. We looked at model performance in the first ECG per patient in a given arbitrary calendar year. Again, 2010 seemed to be very popular. So we identified just shy of 70,000 patients that met those criteria, 6,000 or so of whom had a prior diagnosis and were excluded, leaving a population of about 63,000 at risk. You see about a little more than 10% of that group was predicted positive, the remainder predicted negative. And you can see then the breakdown of label prevalence. So true negatives, false negatives, true positive, false positive, and then a group in the middle here that we were unfortunately unable to resolve because of insufficient echo data on follow-up. But within these groups here, this corresponded then to again, 41% positive predictive value within the subset that we were able to resolve the label for the positive predictions, and 96% negative predictive value within the group that we were able to resolve our negative predictions. So try to put that into perspective here. For every 100 patients with an ECG, 11 of them would have been predicted positive by this model, 5 of whom would have actually been confirmed to have a structural heart disease or one of our recommend findings. And of the remaining 89, only 3 would have been missed by this model prediction. So then we conclude that detection of undiagnosed structural heart disease may enable timely intervention to address disease prior to severe adverse events or other irreversible sequelae. And it's really interesting to note that this work nicely paralleled work that Pierre and Tim were leading concurrently at Columbia here, their valve network. And you can see here the results of this. This was a very similar concept in looking at left-sided valvular heart disease, and you can see similar performance in terms of the area under the ROC curves here. which, as we've now aligned and joined forces here, has led to one of our initial missions here to take this paradigm that we've now each separately proven out in independent data sets, and say that since deep learning analysis of ECGs can accurately detect structural heart disease, our goal is to get these results to every clinician across NYP. So one of the first initiatives that is underway since October is our Echo Next model. Had to, of course, come up with a new fun name. Our Echo Next model, again, it is we're looking at in terms of a staged rollout approach to harmonize our ECG and echocardiography data across the system, both Columbia and Cornell, develop a new model for this type of aggregate composite of structural heart disease, and then begin to actually roll it out into clinical testing and looking at outcomes in a prospective manner. Oh, I forgot I had these bullet points underneath. Apologies. So lastly, want to talk for a few minutes about some of the work that also I think is an important part of our future goals, and that's deep learning of echocardiograms. Echo is, of course, a cornerstone of evaluating the cardiac structure and function in the setting of evaluating disease. And AI is similarly to ECG work beginning to make an impact in echo evaluation as well. You can see here examples of recent studies that have begun to apply ML models to tasks such as image segmentation, here denoting the left ventricular blood pool in echo videos, or for disease detection. This is looking at cardiac amyloidosis, trying to predict the presence of cardiac amyloidosis from echo data. My team at Geisinger had previously done a little bit of work with echo towards, again, the idea of trying to improve prognostic predictions. As a starting point, we had looked at a broad class of all-cause mortality. And you can see some of the numbers here in terms of the study size that went into this particular publication, about 42,000 studies, over 800,000 videos, and 34,000 patients. And one of the main results you see here on the right-hand side, I know it's a large, busy figure, but let me highlight a few elements of it here. For baseline comparison here, we had 3 comparator models. The pooled cohort equation is a risk prediction tool that's designed for predicting 10-year risk of cardiovascular disease. That's represented by this darker red line here. We used a simpler machine learning model of echo-derived measurements, so clinically reported chamber size or functional measurements. That's this pink line here, and the the brighter red line, I should say, is a combination of the echo-derived measurements and other features from the electronic health record. So trying to basically ask a question about how does the data that we can, or the predictive capability of deep learning applied to echo video data compare to all comers for other healthcare derived data. The y-axis here then represents some of the different views. And a typical echocardiographic examination has a number of different views depending on the orientation and position of the probe on the chest. And so each of these rows represents a different view, and then the top 2 represent a combination of across all views, and then all views plus the electronic health record data to kind of provide the all-in model, if you will. So all of that setup aside, now you can see that the dark green line, which represents the aggregate of deep learning across all views, actually outperformed from an AUC perspective, the best that could be done with aggregating across the EHR data. And then there was a subsequent incremental benefit to adding the EHR predictive model to the ECHO deep learning model. So again, showing a proof of concept for this paradigm of having prognostic ability for future clinical adverse event risk of all-cause mortality. I think perhaps the more interesting finding here that I personally am very excited to try to build on is to look at how this model was able to interface with some of our clinical colleagues. So we in addition to that cross-validation proof of concept model, had a separate survey set of 600 patients that we held out from model development. And we then looked at performance of the model represented by this blue line on this rock curve, and asked 4 of our clinical colleagues to similarly evaluate based on looking at one of the videos plus some of the clinical features that went into this particular model prediction, and provide their estimate of mortality risk for the coming year. You can see, perhaps not surprisingly, the model was able to perform better than the aggregation of the clinician predictions. But if we did this in a paired setting where we asked them the same task, the same question of predicting risk, but then showed them the model predictions and gave them the opportunity to refine their assessment, you can see that in each of these cases, moving from the red dot to the blue dot, from the solo assessment to the assisted assessment, the clinicians were able to improve sensitivity for that all-cause mortality prediction in all cases, and more closely approximate the model prediction. So really getting at the point that there's the argument around AI, tends to often go into replacement of clinical tasks. This argues for a more symbiotic relationship, perhaps a collaborative improvement in performance that is maybe possible. And then finally, we also, as a clinical use case, looked at this model, particularly in outcomes of heart failure. So we, in this case, compared the predictive model to the Seattle Heart Failure Score, which is a common existing risk model for one-year mortality in heart failure. And you can see that the area under the curve for our deep neural network exceeded the Seattle Heart Failure model, and looking at it in terms of a Kaplan-Meier survival analysis, at least the arbitrary operating point selected for each model, the negative predictive value was considerably improved for a given apparent positive predictive value here. So this work represents an early, but I think significant proof of concept for the ability of a deep neural network applied to medical videos to accurately make and improve clinical predictions. And again, I'm very excited to try to apply this paradigm in new ways moving forward. So then just to summarize and open up for some discussion, that I've shown today 2 distinct approaches, I think, for targeting interventions at individuals at increased risk for cardiovascular disease. First, obviously, the genome-first identification, and showing how that could help to inform cardiomyopathy and arrhythmia risk before clinical symptoms, wherein we've demonstrated proof of principle, but need to start looking at and identifying additional risk factors to help really tailor the need for more interventions. And then deep learning for clinical cardiology data, such as ECG and echo, and how that's enabled development of a new class in many ways of predictive models with significant potential for clinical impact. And of course, there's a lot of work left to be done here, ensuring model performance is robust in independent data sets, as well as in prospective studies, and then looking at the implementation, robust effective implementation in clinical practice remains an unsolved challenge, and one that we look to be really taking on over the coming years. So of course, have plenty of people to acknowledge from primarily my team at Geisinger, some of whom I've been fortunate enough to recruit to come with me to NYP, and hopefully many of you will get to work with many of them. And of course, my colleagues at Hopkins related to the ARVC work, and Tim and Pierre and many others at Columbia for future work. But thank you all. This is the team that we have here starting out on this this adventure. And thank you all for your time and attention, and look forward to taking questions.
Thank you so much. You know, really, really great presentation, great content. I see some, you know, thank yous there in the chat as well. Opportunity for questions. And some pointed points in the chat to echo. Lucky to have you join us, Chris. Absolutely. I'm looking through to see if I see if I'm missing anything.
Great work, Chris. I mean, I had specific little tiny clarification questions along the way, but I don't quite remember each one anymore. So I can always ask you or look at the recording or whatever. So I'm not worried about it, but thank you so much.
Sure. Thank you.
I guess, Chris, I have a question. This is Noemi. Thank you so much and you and I are supposed to meet tomorrow, so we can talk much more about it. But I wonder about the, you know, there's all this this new area of human-centered AI right now, and a lot about interactions between AI and clinicians in particular, and trust and acceptance of acceptability of AI systems. Have you guys thought about how you would go and study this in particular, given that let me just add a little bit of background to why I'm asking this question in particular, which is that you know, the deep learning is on something that is very quote unquote objective as an input, as opposed to, say, documentation about a clinician about a patient, which is more subjective and prone to errors, or you know, any ideas that the clinicians might forget to put into the input. Is this something that you guys are interested in or looking into, and could you talk about how you were thinking about these questions?
Yeah, no, absolutely. I think that's definitely something that is needs to be front of mind as we move along here. I think you're right in saying that in some ways, working with seemingly objective clinical data like images or signals should hopefully help to reduce some of that susceptibility for bias that might be present in something like a clinical documentation or other features like that. But I don't think it's at all safe or fair to assume that there isn't some potential for that type of bias. And the way that I tend to think about that most is in the context of who has a study available for us to be evaluating in the first place, right? I mean, that there still needs to have been a clinical encounter in which an ECG or an echocardiogram was ordered and performed to be able to train a model and run inference and try to predict disease or disease risk. And so thinking about that in the context of making sure that the work that we're doing is generalizable and equitable and fair, I think is, at least in my mind, where a lot of that thought needs to go in. But no, I think that's absolutely something that is going to be important to think about and consistently evaluate as we move towards implementation and use of this.
Thank you.
Chris, for a second, could you just clarify? I should know this from the presentation, but sometimes I wasn't sure which evaluations were truly fully prospective and which ones were like, there's a separate test set and it's kind of prospective, but it's done retrospectively. So it's not really fully prospective. So I wasn't sure which ones were which.
Yeah, sorry, I'm sure I could have done a better job of clarifying that. So, I mean, strictly speaking, none of what I presented here was done in a truly prospective fashion. There were all of the results were based on some use of retrospective data. What we had tried to do, in particular, for example, the atrial fibrillation study, and again in the recommend study, was to separately do a cross-validation, patient stratification and cross-validation across data for a proof of concept type approach, and then separately simulate some type of prospective application by training the model only on data prior to an arbitrary point in time and testing it on data after that time. But really, it's still heavily biased by a retrospective analysis, because you still there was no prospectively driven intervention to try to acquire the data needed to definitively answer the question, right? That's why for example, if I can try to scroll back to it quickly. In this figure here, right, there's this big gray box in the middle of unresolved, because this is still reliant on retrospective data, and there weren't data available to be able to definitively say, okay, among this group of 4,000 some odd patients with that we predicted had disease, we don't have enough data to say whether or not that was true. So still limited by the retrospective nature of it, but at least trying to approximate what a prospective deployment might look at in terms of considering a truly at-risk population.
So and that's good. Okay, so I understand that. And then at NYP, are you starting to do fully prospective? I mean, is that this next step?
So yeah, I mean, Pierre and Tim really got a head start on that prior to even me showing up, so I can't take any credit for that, but have started to with again the ValveNet model that they've been working on, have started to truly prospectively test this out within newly acquired data, and actually go through the work to acquire the echoes to definitively label each prediction. There are teams still at Geisinger that are similarly doing the same. But yeah, don't have data in hand yet to really kind of read out what that looks like, unfortunately.
And then and that FDA approval for the company, was that based on prospective or just retrospective data?
No, that was based on so it wasn't true
not approval,
FDA approval, right?
stage.
The breakthrough device designation, but that was based on the same paper, or the same data more or less that was in the paper. I mean, that there were, I believe, some additional kind of sub-analyses and things that were done as part of it, but still based on that retrospective evaluation.
And that's appropriate because it's not an approval, it's the first step of the thing, and that's fine.
Yep.
Okay, thank you. I see Lauren has a question in the chat.
I can read it. Sorry. Thanks for your presentation. This is kind of similar to what Naomi was asking in regards to, I guess, working with clinicians and getting things on board clinically. And I was just wondering, like, in an ideal situation, like what the next steps would be to kind of get this to be used and how it would be used. Like, is this something that would be a diagnostic tool versus a physician alert? Or would it just be something built into the EHR, that kind of thing?
Yeah, no, absolutely great question. I mean, something that there's still a lot of regular, I won't call them arguments, but engaged discussions about what that actually should look like, right? I mean, I think the first thing to say is none of this in my mind is driving at a diagnostic quality test yet, right? All of this is, all of the, at least the examples that I talked about here are, I think, more directed towards an opportunistic screening model of you have patients who are already getting an ECG for any number of different reasons, and you have predictive models built on top of that technology to be just silently evaluating risk for other things that may not have been the primary indication of use of the ECG in the first place. And the model prediction, I don't think it is deterministic of a specific diagnosis, but would be meant to provide in some ways a physician alert, and I'll use that term cautiously because I know that that carries a lot of negative implications, right? But an alert to say, hey, this patient is predicted to have increased risk for undiagnosed atrial fibrillation. You might consider getting a 2-week patch monitor to observe if there's any evidence to support that, right? Or similarly, patient is predicted to have some undiagnosed structural heart disease. Consider getting an echocardiogram to confirm or rule out. So it's meant, I think, to be a screening mechanism, but then that raises the question, as you say, of how do you actually present that information in a useful, non-annoying, non-obtrusive way that it's actually going to be useful in a real world context, and that is definitely an open question. That I hope we'll learn a lot of what to do and what maybe not to do over the next few years.
Yep, fingers crossed. Thank you.
Thank you.
Chris, you were too kind. They definitely are arguments because we have no idea how to do this. Yeah, and I mean the pop-up alerts are really hard because when Tim and I were chatting with Chris, and Lauren would probably reiterate this, and other MDs, in the 7 years I've practiced at Columbia, there's never been a single time that a pop-up alert has actually had me change my clinical decision making. It has only annoyed me, distracted me, or bothered me, or had me sign some billing thing that is needed. But not once in 7 years has clinical decision support guided my clinical decision making. And so that's a pretty tough place to start from.
Yeah, same. Yeah, you're right, Pierre. Same experience.
Chris, I have a question. This is David. So, I haven't been in AI for a while, and I might, maybe these questions have been posed and answered already in some regard, but when you have a tool like this, to what extent do you just kind of put the black box in line for clinical care and say, okay, well, this can be an aid to decision-making? And then to what extent do you take that tool and feed it back and try to tease apart what complex interactions and the inputs it seems, which could potentially add to the knowledge of clinical physiology?
Yeah, it wouldn't be a deep learning talk without the black box question. So thank you. Although I think it sounds like you have a slightly different inclination on it than most times I'm asked a similar question of how can you trust something that's a black box? You're asking it, if I understood, more from the standpoint of, can we use this to learn something new physiologically? And I have seen that, particularly in the context of, and I'm blanking on the exact details, but using, for example, an ECG model, trying to identify then what ECG features were present. I'm assuming it's probably AFib, right? So what was the model learning about the ECG that was predictive of AFib, and then running a genome-wide association study of that and identifying genomic SNPs that were associated with model predictions. And I think that gets into the comment I made about the longer term prognostic significance that we observed in our model as well, right? That suggests that it's learning something interestingly about the patient physiology that may have some type of value for discovery research. That's not an avenue that I've traveled down, but I can see how that would be of real interest. But yeah, I mean, I think, most of the time the black box comes back to that question of clinical trust and ability to use it. And I think just to preemptively perhaps answer that part of the question, I think, it helps in our case that we're, again, not focused on diagnostics strictly, but, for risk and screening purposes. And so, there's still by design and intent, a physician or other clinician who's, interfacing between model outcome and patient decision making. But yeah, I think, in my mind, the black box question is not something that's going to be easily solvable in the short term. And so, it's while the technology and the methods for trying to solve that are still in development, I think it's just important that we continuously evaluate, from prospective clinical studies, what are the implications of using these tools, and do we actually see improvements in diagnosis and hopefully even patient outcomes through their use. And that'll help to also build trust even without that explicit interpretability that I think people generally want.
Okay, thank you. I wasn't implying black box as a negative connotation,
Okay.
by the way. If it works, it works. So
I've just been scarred by that question too many times, so that's where my mind goes.
We may have time for one final question, if a quick one. Or we're now at 2:59, so it may make sense to wrap up. And Chris, thank you very much for your presentation, great discussion. And again, welcome to NYP and Columbia.
Thank you.